Good evening, everyone. Welcome to the Lead Extraction Workshop webinar. My name is Yongmei Chan, electrophysiologist at the Mayo Clinic. On my side is my colleague, Dr. Siva Mupuro, and he is the Device Service Director at the Mayo Clinic. So today we are planning to present two very interesting cases. So Dr. Mupuro is going to introduce the first invited speaker, Siva.
Thank you, Yongmei. Today we had the pleasure of having a colleague from Australia, far away, presenting as an interesting case, Dr. Gareth Wynn. He is a senior lecturer at the Royal Melbourne Hospital. He obtained his medical degree from Manchester and a doctoral degree from the Imperial College in London. He did his training at Manchester, Wellington, and Liverpool, and he is the chair of the Lead Extraction Committee for the Cardiac Society of Australia and New Zealand. Thank you, Dr. Wynn, for joining us and presenting this case today. We appreciate your collaboration.
Thank you, Dr. Malpuru, for the introduction, and Dr. Chow as well for the opportunity to talk. It's actually nice to be able to be involved in a US meeting that isn't at 2 a.m. It's a relatively pleasant 10 a.m. for me. So that's really nice to be able to do that. And thank you for the opportunity. I don't need to go through my introduction because that's already been done. And hopefully we'll get to the title and the reason for that in time. My disclosures are fairly widespread. I don't think we have any particular preference for one system or another. So there's a particular referrer in our local region who's a good friend of mine, but repeatedly refers me the most complex patients I get, and this is probably the most complex of the complex ones she sent me, and actually was a case we did just last week. So this lady has Carney's complex. I'm sure nobody needs to Google that, and I certainly didn't either, honestly, and recurrent benign tumours for which she had a left atrial myxoma excised back in 2004. I haven't put her age on there. I think she was 15 at the time of this. And there was some resultant conduction system injury during this. Now, she was actually in the UK at that time. We don't have any records for what went on. It seems to be a sinus node injury that occurred, or that seems unusual for a post-operative surgical issue, but we really were not clear. We didn't have any records from what went on. She also had issues with a junctional tachycardia and reported that she had an ablation for that back in 2019, which had some improvement, but didn't cure the situation. And her first pacemaker was put in 2004 after this conduction system injury. And we're told that 9 months after this, she had a device erosion, and they decided in this 9-month-old device that instead of removing it, they would revise the device and rebury it. And I believe that over the course of many years, she had over a dozen revision procedures on this. She then moved over to Australia and lived in a couple of different states. And as we're talking through this story, she then tells me that in 2015, they were really struggling with things, and so they put my pacemaker between my ribs. And at which point I thought, this lady's completely crazy. And I'm just talking to her saying, no, you must have this wrong. There's no space between your ribs. It can't go between your ribs. Yeah, they must. What are you talking about? And she kept saying this, and then her partner who was with her piped up and said, I can't remember. They said it was in the pleural space. At which point I sat up and just said, hang on, this is not a term you just know about for fun. There's something going on here. And they also, as well as doing this procedure, which to this point I really was very uncertain what had gone on, and they also decided that the leads apparently didn't stretch to the pleural space, so they thought they'd just cut the old leads and start again. So this is the procedure that she had. It took a bit of Googling again. And this is most of the reports on this of pacemaker implantation with the device in the pleural space, not the leads, the device itself, come from the literature from 1970s, almost all in pediatrics. Actually, I think from as far as I can tell, all in pediatric literature, and generally designed to put a device that would otherwise be very protuberant and large on a young patient somewhere else. Really, there is one paper on this more recently from 2022, but most of this seems to be a procedure that was tried very early on and now just isn't used anywhere. Certainly, I haven't come across anybody who's ever done this. I did actually bump into the surgeon who put it in, who did this at a Christmas party this year, and just mentioned that was an interesting thing you did there, without trying to explain the fullness of my incredulity of what he'd done. So she'd had this device put in, as I said, with the leads cut. And then she attended the emergency department, I think, virtually every week for 6 months with agonizing pain. And her description of it was that the device was banging on her diaphragm. So they then had a plan. I'm not sure whether there was a full plan for extraction, but certainly to remove the device, put it back in what they called a submuscular space. This was complicated by a hydropneumothorax from the surgical procedure. But the device was now back out of into a more standard positioning, but still in an area that has shown itself to have recurrent infections. A year or so later, she had the next episode of cellulitis, and she seemed to be okay for a few years. And then over the last year or so, has had recurrent episodes, started on chronic suppressive antibiotics, and had at least 2 admissions whilst on antibiotics with further cellulitis of the device. So I'm sure that the audience here who's come along to a lead extraction don't really need to see the consensus document guidelines as to what we should do with pocket infection. But nowhere in there does it say continually bury it away and try and hide it for the bugs. And I can't see the bit that says put it in the pleural space either, but maybe that's a different version of the guidelines I've seen. And we all know that the guideline recommendations are that if you've got a clear pocket infection, the device and the leads have to be removed. And if you are revising a device, the guidelines also, the consensus document also suggests that the leads need to be left in a state that would allow future extraction. So another bit of the guidelines I think this surgeon didn't read. So this is her chest x-ray. You can see the rather unusual cardiac silhouette, which I'll come on to in a minute as well. You can see that one of these leads has been cut sort of reasonably long over towards the sort of lateral side of where the ribs are. One of these looks like it's cut extremely short, right into where you'd think the venous puncture site might be. And just for good measure, there's a little bit of lead fragment just sitting there in the pocket, not connected to anything. So when I submitted, when Dr. Mulpera was looking through, he said, please do talk about the leads that you had here. The trouble was that might be easier said than done. So we have no record at all of what these 2004 leads are. And they've both been cut. There are no medical records saying what they are. On the chest x-ray, we can work out that she has a passive lead in the atrium, a passive lead in the ventricle, and an active lead in both the atrium and ventricle as well. But that's all we have. So we go to the device. And first thing we note here that it says the leads are 2012, which really did throw me because we think the new implant is 2015. So genuinely have no idea how that got in there. And we have all the information there of the lead 1, which I don't think has actually put what location it is Medtronic. And that's all we get from that. We do, for the second lead, get the lead number and discover that's a 4457 passive fixation fine line Sterox lead, which is probably one of these leads that you wish you didn't know was in there. And from the serial number of the Medtronic lead, which was in there, we discover this is a 3830 lead, obviously a very topical lead at the moment, for conduction system pacing, but not from a surgical implantation in 2015. So I mentioned the shape of her cardiac silhouette on chest X-ray, and I don't know exactly why it sits like that. She's quite a tall, reasonably tall, very thin lady, but I probably didn't appreciate this. But working with a cardiac surgeon who I work closely with, You can see here, he pointed out, this lady's had a sternotomy and has had the pericardium left open rather than being closed. And he points out here, I don't know if you'll see a pointer on that, but just under the sternum, you can see on the left-hand image, you can see the sternal wire, but just under that as well, you can see the right ventricular myocardium. So in not closing the pericardium, this has become a myocardial wall that's effectively just adherent to the sternotomy, which is obviously not what you want if you're going to need to do an emergency sternotomy. And he was talking through how the process of this usually would be a very slow and deliberate process where you're actually going on to bypass, draining the heart to get it as far away from the sternum as possible prior to using the saw. Here you can see that this is a really worrying image in that there's definite potential that if you put the saw onto this in emergency, you just go straight through the right ventricular free wall. We did talk, we had this meeting, this case discussed in our multidisciplinary cardiology meeting, and we decided we would go for a transvenous approach rather than an open approach, because both of these come with considerable risks. There's some published data looking at whether having a prior sternotomy protects you or not. And overall, for mortality, it seems to be equal. You're less likely to have a bleed, but if you do have a bleed, the chances of surviving it are lower, so it evens itself out. And obviously, this is a particularly bad appearance from the sternotomy, as mentioned. The only one good thing we did see, and we don't routinely do CT scans on our patient preoperatively, but we did in this case, looking at trying to get an idea of what was still inside the pleural space potentially. But you can see maybe in the center of the right-hand image that the leads seem to be fairly central. They are close together, so you'd expect lead-to-lead binding. But nicely, none of them seem to be actually in contact with the SVC, which is the only one nice bit I felt about this case.
So Gareth, the sternotomy was for the pleural placement?
No, for the myxoma. Then the pleural placement was via a left thoracotomy. So this is our standard setup. We do most of our cases, or whenever we can, in a hybrid operating theatre. Possibly the most important thing of this setup is just in the bottom right-hand corner, you can see some folded hands, and they're the hands of my cardiac surgical colleague standing right beside me, scrubbed. He's actually part of the extraction team, so I've trained him as an extractor as well. But obviously, if you do run into problems, having a surgeon who's already got his gloves on and you've got a saw on the table is going to minimize as much as possible the delay. I'll just go through a few bits here. So you see our groin preparation, and because it was a redo, would have been a redo sternotomy and a highly risky redo sternotomy. We've got atrial and venous lines in the right groin, and usually we will put our snare and things in that groin because manipulation is easier. But if we do think there's a high chance of having to go onto peripheral bypass, the surgeons much prefer the right route. It's straighter for the big catheters that they need to put in. And this is our standard setup if we do have a patient with who's had a prior sternotomy. One thing to be aware of if you're putting these lines in is that they are big tubes. Hopefully, most people use ultrasound for their access. But generally in EP, we often go with a short axis view relatively directly into the vein because we've got relatively thin and flexible catheters we're using. When you're talking about the rigid, large ECMO-type cannulas, if you're trying to do an acute bend like that, you can really run into difficulties. So the surgeons that I work with are very keen that we use a long axis view as well and try and get a very gentle approach into the vein, so that we can hopefully, if we do need to do that, then peripheral bypass is able to be instituted. She's pretty thin, this lady, so actually that imaging was easy. On the right-hand side, you can see we've got a 12 French sheath in through which we've staged a bridge balloon. I haven't got it, but you can just see on the fuller image now the little sticker there down towards the bottom right of the image. So that's where we need to push up to be in the SVC. Sorry, I'm going the wrong way. And then you can see a needle's eye snare, and you can see another thing. You can see a little three-way tap on this. And this is a hemostatic suture that I put round. So I will usually close these with a figure of 8 suture at the end of the case. But I quite like putting it on early on in the case and just tightening it a reasonable amount with a figure of 8 suture. And that stops that sort of oozy bleeding, or does a lot to stop that oozy bleeding you often may get around the cases.
It looks like you have a 3-way stopcock right there,
Yeah.
right? Very nice.
And so I'll go on to a little bit about this. You can see we've got a laser loaded onto this lead here. You might be able to make out running to the left of my hands. We haven't actually got a locking stilet through this. We've got a thick Ticron suture because this is the 3830 lead, obviously no lumen to put down it. And this can be difficult in terms of working out how you extend this through, because it doesn't take much for these leads to bunch up and suddenly be difficult to get through. So you need to be able to find a way to try and keep them straight so that the pin can go through the oversized sheath. And this stage would have been a 14 French laser glide light sheath I was using. Just another point on the hemostatic sutures, and this is something again our surgeons brought in and changed. Just above the black box, which you just covered the nipple on there, you can see a bit of tubing there, and that's a surgical snugger. And we found this really helpful with a thick PDS absorbable suture. So it's about a 1 suture, really tough but slippy suture, and we do purse string sutures around all our venous access points and close them off with surgical snuggers, and we could just bring them on and off and try and minimize that bleeding that is always part of lead extraction. You often can't do much about the stuff that's coming out of the back of the sheath, but this is one way in which we found that we've had better hemostasis for the procedure. So the first thing we're doing within that is opening up the pocket, and we find this little fragment that's been left there. So we're pleased to be able to get rid of that, because obviously even after all the other work, if we leave that in there, we may have ongoing infection. As is often the case in these, we don't actually know exactly what is in the pocket. We can see what's radio-opaque. We can see if we find things, but there's every possibility there might be non-radio-opaque material in there that we never find, which is a risk for ongoing infection. But in the end, you can only sort of get out what you know is there. This is just a little video we found that said the lead that had been cut short did have a little bit of insulation left. So for the cut long active fixation ventricular lead, we put an LLD EZ locking stylet down. Obviously, no stylet on the for the 3830 lead. For the fine line lead, we use a bigger stylet because it's got a bigger lumen. So we use an LLD number 2, and we just tried to get an LLD EZ or EZ down the insulation of this cut lead. Didn't get very far, but it did give us a little bit of traction on it, which we otherwise had no control over. So here, it's not super easy to see, unfortunately. You can see we've got the laser on one of the leads, and we're not really sure which leads is which for the cut leads. But we do have dual traction here with the needle's eye snare, and pulling down and trying to give us a nicer rail, as Dr. Schaller has published on, to try and get through the areas of adhesion. And as you might imagine in the leads, we've got quite a lot of adhesion here. You can see we're moving backwards and forwards, and we've got to the first point. We actually got through initially under the clavicle reasonably easily, but we got to our first point where all the leads are bound together. We're trying with the laser here to get through these.
But Gareth, is this the only fine line leads that you grab with the needle eye snare, or all atrial leads?
I couldn't differentiate between them with them, and needles eye snare. I find snaring is a beautiful concept when it works well, and an incredibly frustrating and difficult concept a lot of the time. And occasionally you get lucky and manage to snare an individual lead, but often you just get what you get. So at this point, we've got the sort of bunch of leads in the in the sort of SVC upper right atrium, and we're just using all of those. As I said, we've got a rough idea of what the other leads are, although I don't think it actually said where the fine line and 3830 were. And we've got 2 other leads which are cut. We don't know what they are, and we don't know which one is which. So it's sort of trial and error. And certainly at one point we sort of moved down, that's not the lead we thought we were on. We do try and label them all if we know what they are. But in this, we knew which bit was which, but we didn't know where they were attached on the other end. And so as I said, here we've got stuck. We're trying to get through, and this is something I think that is an important point, or certainly my practice, is that you're not spending too long on one lead. If you're ever asked to extract just one of multiple leads, that's always a much more difficult procedure, I think, because trying to attack binding points from one lead to the other and attack them with different angles and with different forces on them, I think is very useful. But occasionally you don't have that option. It's not that unusual that, particularly if you've got one lead, you're replacing a ventricular lead, we do reasonably often replace end up sacrificing the atrial lead and taking them both out and put new ones on so that we can get that approach. However, depending on what the leads are, if you've got an old coronary sinus lead, you don't know what's going to be left in terms of getting in there. So that's a lead you really don't want to sacrifice if you can avoid it. So again, we've switched now to another of these leads, just attacking the same binding point. You can see some of the lead has moved, and there is movement between the leads slightly further on. But we're just again trying this binding point from a number of different angles, going on to different leads, still using the laser at this point. And then going on to the final lead. And at this point, we do manage to break up the adhesion, at least for this lead. And you can see we can get the sheath a little bit further down. But actually, although the lead is free, you can see that this sheath is struggling to advance much past that original point, likely due to some snowplow of insulation or some calcification of the lead at that point. So we have made some progress, but certainly not down to where we might be able to remove the lead. And you see now, so the next step we've gone on to here, still using the laser at this point, but now advancing the laser, the outer sheath, so that we've got a bigger diameter over the lead. And you can just hopefully with the arrows see with the 2 points there. And we've got a lot further down with the outer sheath, but the inner laser sheath is still about where it is. Again, suggesting that there's some sort of impediment to passage there, but we can get a larger sheath down. Again, make some further progress. Here, we're just really extracting with the outer sheath. At this point, we're not totally. This is one of the points where we're not totally sure which lead we're on, and we start to realize, okay, this is the atrial lead, and realize that this is the 3830 lead. We knew it was the 3830, but knowing it's in the atrium. But even if you try and follow the course of those leads, it can be quite difficult to work out exactly which lead is going where. I'd really try to avoid laser or activation of mechanical sheath in that upper SVC area, if at all possible. And I'm very pleased if we could advance with an outer sheath or with the inner, the standard sheath, but without energy to try and reduce the risk of injury to the SVC.
Gareth, I think it's a great technique you're using here. Do you have any concern about the mismatch between the small lead and the large sheath? Do you have any comments?
So yes, I do. And I think this is, obviously removal of 3830 leads in particular has been a key thing that lead extractors and implanters have been discussing for a while. And I think initially we were worried that you were going to just pull out huge chunks. And when they went to left bundle branch pacing, when people went to that, I think some of us imagined you'd suddenly create this enormous VSD. I don't think that's true. I think the leads are actually not bad to remove. And the limited evidence that exists seems to back that up. But I definitely think once you get past a certain level of age of the lead and you have issues like this where you've got to oversize the sheath anyway, and you've got... And then you're getting stuck even on this thin lead, so you've got to use an outer sheath over it. Or if you're having to go up to a bigger laser or tight rail, then you've got a lot of mismatch there, and I think that's a worry. I do have a picture from another presentation just off that of a 16 laser with a lead through it, and it's a really big area that's unprotected. Again, trying to avoid active use of the leads, using the blunt end of the outer sheath. You're using an outer sheath rather than the beveled end. I think are ways of reducing this, but I don't know there's a way of completely getting over it. We're pretty lucky in Australia in terms of our ability to use the tools that we need, but equally we're expected to have some fiscal responsibility, and using 3 lasers and 3 tight rails for every case is going to cause problems. So we're trying to get that balance between between the tools we use, being sensible with them, and also using the best tools for the patient. Yeah, I don't have an answer to that, but I agree it's an issue. And here we've switched over tools, so we're now onto a tight rail. Again, you've got a bigger inner lumen here, and using this where the laser was getting stuck, we are able to make a little bit more advancement down towards still that same area that's causing problems, and just sort of coming backwards and forwards. You sort of say, in case you're caught up in an area, just coming back a little bit, re-advancing, and trying to make your way down. And we did, after a while, get the tight rail down to the tip of the lead, near to the tip of the lead here. And you see again, I'm sort of at times I tried to pull it in just before this, try and pull it right into the lead, into the sheath, so that I've got counter traction, and not managing that. So I'm saying, well, if I just push down with this, can I get traction in that way? Because I can't get quite the traction and counter traction that I want at the myocardial interface. And actually, we'd broken up enough that when we went to switch, I think I went to put the outer sheath on this as we took this lead out just after this, it gave, and the lead came out in its entirety. So I don't have that as a video, unfortunately. But we did get this 3830 lead out from the atrium. It's the first 3830 I've taken out from a right atrial position, taken plenty out from the septum, but first of these, so it came out reasonably okay, although difficult. So we're now going back to the other leads. And here I've gone back, decided at this point to go back onto the laser, and I'm using back onto the active, onto the right ventricular leads. I think we're on the fine line lead at the moment, and just trying again with different tools to try and make our way down. My Zoom image is in the way, so I can't actually see exactly what's going on. So I've moved that, so it's better. But again, you see sort of difficulty making progress, and just trying to make our way down, and trying here not to use laser as much as possible, using the outer sheath. And if you do have to do laser in the SVC, I feel like if you've got a blunt edge of the outer sheath forward, and you can actually laser the adhesion within the sheath, it's not always as effective, but it certainly feels like a safer way to use the tool if that's possible. And now again, unfortunately, this wasn't. We missed another bit on our storing, because if we press our foot back on the pedal too quickly, it goes. But you can see on that actually the in the middle there, the tight rail, the fine line tip is sitting on its own, and it's snapped at this point. And I'll just show you an image about that in a minute. And we're back onto the 2004 active fixation lead. We don't know the details of this lead. We're just trying to work it down with the tight rail, and we're up to a 13 tight rail at this point. So the largest inner diameter that we've got, to try and get right down to the tip here. And this is a nice paper looking at different leads. And this is something that's quite common in the fine line leads. And actually, I think, although it hasn't said it here, but the older St. Jude leads as well, very often, particularly their passive leads, will break off at the tip. And this paper looked at these different things and showed that it was a very common yielding mechanism for the fine line lead, that it's difficult to get the tip away. I think it's usually fairly encapsulated. So even in an endocarditis case, you're probably okay from an infection point of view. It does have an impact in terms of future MRI, obviously, which is a real issue for us in all sorts of circumstances in Australia. But in terms of a safety point of view, it's often nice if you're really struggling with this. The tip breaking off is sometimes a bit of a relief, that you know that the failure has been in the lead rather than in the myocardium. And this is also something we sometimes get to. I've tried with the tight rail here, and then I'm trying to come back to put the outer sheath on, and I'm actually struggling to get the sheath back here. And we've the lead is stuck within, and I can't really go forwards and I can't go backwards. So again, I've gone up with or attempted to go up with the needles eye snare. I often find that this sort of wraparound technique is my best chance of getting it in there. It's often hard to get it otherwise into the area that you want it to. Although, as you see here, that lead does sometimes quite often still slip out if you haven't perfectly aligned it. But by just providing some sort of counter traction with the sheath, we were able to pull back on the lead without pulling too much on the myocardium, which was causing some hypotension and sort of idiopathic ventricular rhythms at this point. So I was pleased to be able to do that. And then now we've got the outer sheath on. You can see the tight rail is again. And now we've got the outer sheath to the tip. We're putting pressure back on both of these. I think another point that I think is important in my practice when we're talking about traction and counter traction, in these circumstances, you're not talking about something going forward and something going backwards. You're talking about both of these going backwards, but you're just pulling more on the lead than you are on the sheath. So it's a relative counter traction as opposed to an absolute counter traction. Because what you want to see is that when you've actually got the tip there that's stretched out, and when it gives way, you want everything to come backwards. You don't want to have pressure on your outer sheath that suddenly jumps forward and potentially goes through the myocardium. So although it still makes you jump a bit when this jumps, or it makes me jump anyway, I think that's nice. That's the direction you want things going when this lead comes out. And this is that lead. You can see it's sort of pretty fibrosed. You can see why we struggled to get right to the tip of it. And you can see a little bit of the stretched out helix there as well. And I had this point thought that although this is a 2004 passive fixation lead and we've already got a bit left in there, this seemed to have a relatively long tail to it. And as far as we'd got on it, I felt like it wasn't too adherent to the atrium myocardium. So here I've gone up and used the needle's eye snare again to snare that the bit of the lead. I've pushed an outer sheath up the workstation to again provide that traction and counter traction, and just with relatively gentle pull down with the snare now within the sheath. You can see that doesn't jump so much in this one, just comes away in a few moments, and we bring that away from the myocardium without too much of a problem. Now you can see it just giving there. And this is that lead in a couple of different views. You can see how we've got it bound up. The tip of it's come out with all its tines, and it's come out relatively clean, but it's just wrapped up in the snare. And this is her post-operative chest X-ray. You can see that everything looks similar. She doesn't have the leads in there, apart from that little tip of the fine line lead. I'm going to call this, and so this counts as a clinical success. And we've got a small fragment of that lead in there. And I think, as I said, for this particular lead, that's extraordinarily common. And in terms of the main outcome of the procedure to deal with a recurrent pocket infection, this has no impact on this at all. And that's certainly a much happier outcome than having to deal with an injury. So maybe I should have left the atrial tip in there. But I certainly wasn't going to chase after the ventricular tip and try and get that where it's buried in the myocardium and potentially bring out half the tricuspid valve with it as well. So we left that in there, and I was happy with that. She grew a coag-negative staph from the pocket. Just a little personal point that I think is worth remembering is that if you do try and get samples. If you've got a pocket infection, don't send lead tips, because you drag them through the pocket, you're always going to contaminate those samples. Your ID team will be upset with you that you haven't sent tips because they don't know. They say they don't know if it's endocarditis, and you just have to educate them that the bugs on the tip that's been through a grotty pocket full of pus are not going to tell you if it's endocarditis. The clinical picture is going to tell you that. But if you are sending tissue samples, you can see that swabs often don't grow as much as tissue from the pocket. It's really good to send a decent bit of tissue off to try and get your microbiology in there. So for me, I think her outcome, she made an excellent clinical recovery. She had a 12 French sheath and a 16 French sheath in the left groin. So that was sore for a day or so. She remained in sinus rhythm. She still did this thing that we saw when I'd seen her in the rooms a few months previously of a junctional tachycardia when exercising. But she tolerated that well. She had no bradyarrhythmias in about 48 hours of monitoring. I'd programmed her device to VVI 40 prior to extraction for a couple of months, and she said her exercise tolerance was a little bit lower, but generally she was doing well. And given the complexity she had, both her and her main physician were very happy for her to be discharged without a pacemaker reimplant at this point, obviously for further thought through. So in conclusion, I use this that a stitch in time saves 9. And when I was a child, I never understood this phrase. But yeah, there were many opportunities to do a much less complex procedure that I ended up having to do. And at 9 months old, yeah, it's disappointing to put a device on the other side of a young girl, but you could have saved her 20 years of recurrent infections and a really high risk procedure if they'd done that. And there were multiple opportunities later on as well. It's possible to get good outcomes even in the most complex cases, but we really need to understand the leads, the anatomy, and the suite of extraction tools that we have available to us. And as I said, I'm lucky to have those. You really need to set yourself up for success, and preparation is essential in this kind of study. But I think even in the most prepared case, you just sometimes need to get lucky, and we did with less. Thank you very much.
That's a very philosophical conclusion there. I can't agree more with you. You showed us very good technical points throughout the case. The case was masterfully done. Thanks for sharing that case.
Thank you. It was one of these cases. I wasn't quite sure what I was going to present. And when she came up the week beforehand, I said, I have a fair idea. This is going to be unless things go horribly wrong, this is going to be my case for next week.
So you have that 2 amputated leads, and then you found those 2 leads easily in the pocket?
No, so the one that we no, we didn't. So I actually did all the groin prep. My cardiac surgical colleague did the pocket to begin with, and at one point he thought that we'd found the bit of insulation, which we worked out was connected to the very short lead, and he actually thought the little fragment that I showed early on was the other lead. And I said, no, I think that's in the pocket as well. And so we did a bit of sort of screening with a tool, just moving your forceps or something over it. Oh, okay, it's under here, and then dig down, and okay, here it is. But we didn't know whether a lead cap had been put on. We didn't know whether the suture cuffs were still on. You can try and look for them, but you don't always find that stuff. So it is possible we'll find other prosthetic material in there in due course. I hope not. But we got out everything we could find and get rid of.
Yeah. If you couldn't find the cutting point, you may have just do that from below that.
Yes. I have to say, I assumed we would get more. We would have to get more of these leads out from below. And I guess in the end, we did get the very short lead. The other one had been left with a good few centimeters in the pocket, so we could get a locking stiletto down that, so that wasn't too bad. But yes, in the end, it broke from a superior approach, so I had a little bit less to grab. But yes, that one that'd be very, very short, I had to take femorally.
Yeah, congratulations for the successful case.
Thank you.
It's wonderful.
Yeah, no, I think I'm going to present the case, and then we'll come back to audience questions. And colleagues, if you have any questions, put them in the Q&A, and we will try to answer them in the end. So here, basically, I wanted to share a case of leadless pacemaker. We're putting in a lot of leadless devices, and should we be prepared for a ton of them to be extracted down the line? Something to ponder on. So I'll show a couple of cases of, leadless pacemaker extraction, and show you the tools that we need for a successful procedure. I don't have any relevant disclosures for this particular talk. So my first case is a 65-year-old gentleman who presented with recurrent bacteremia. He had MSSA bacteremia. His prior history, he has history of rheumatic heart disease, had aortic, mitral, and tricuspid valve replacements. And during this particular admission, when he presented with bacteremia and sepsis, he was also noted to have mitral valve prosthetic endocarditis. So prior history of bypass surgery, 2 prior atrial fibrillation ablations, and eventually he had an AV node ablation with a leadless pacemaker that was implanted. One may ask a question, when you have so much prosthetic material and Staph aureus bacteremia, do you really need to take out a leadless pacemaker? Maybe I'll ask Dr. Cha and Dr. Wynn about to comment on that.
Yeah. Dr. Wynn, do you want to have some comments for this in this specific case?
I'm presuming that there wasn't a plan to remove the prosthetic surgical material.
Yeah, he's too high risk he's already had 3 sternotomies and too high risk for any surgical procedure.
Yeah, I don't know. I think it's a difficult situation in this. If you've got a fully endothelialized system, you'd think the chance of that being involved in infection are very low, and you've also got a potentially risky procedure to do. Although maybe a prosthetic, all that surgery, maybe the myocardium is protected. Equally, however, maybe this is your lowest risk intervention in somebody who's otherwise extremely unwell, and it's a case of, well, if we get a chance, we can. Of course, he's pacing dependent, which does make the situation more difficult as well, because you've got to put something else back in there as well.
Yeah, I think it's a very, very challenging situation, because the patient's dependent, and the micro is implanted probably a shorter time, right?
Yep.
Couple of years. So it's not a very long time. So I think if we say we do not remove the micro, then we may have a chance that left some infection source there.
Yeah.
So I think this you can debate for a long time. Probably people can stand in both ways to argue each other. But we do look into our data in the past. When patient has a prosthetic valve, single or multi-valve endocarditis, and then majority patients when we do the lead extraction, I think we look into our 60 patients with prosthetic valve and endocarditis and the systemic infection. After we remove the lead, only very few cases really have recurrent infection. So when we clear up all the transvenous lead, that was in the past with the transvenous leads only, we did clear 90% patient infection. So that's a very positive result without touching the valve.
Yep. So in this patient, that was the reasoning. The ID team met that let's take out the infected PICC line. Let's take out all the bioprosthetic material that we can take out and give him an extended course of antibiotics and see how he does with that. Especially,
presumably, I forgot to ask, presumably this is a bioprosthetic tricuspid valve.
It is, yes. So here is the first RAO image. You can see a mitral valve, aortic valve, and you can see basically we have a large outer sheath, and through that a large curved edgulus, and we're putting a gooseneck snare on the device in RAO, and we have a temporary pacing lead in the right ventricle. When we take out the micra. So in LAO, you can see that this is the bioprosthetic ring of the tricuspid valve, aortic valve position, and a mitral valve. So you can see that the gooseneck snare is this is a 25 millimeter gooseneck snare, is right around that micra there. So as we have it on the micra and we cinch the gooseneck snare, the device pops out. Even, just on the body of the device, we had it on the body of the device, and the device becomes loose. Here you can see it's kind of perpendicular to the long axis of the sheath, and it's hard to get it into the sheath because there's a mismatch between the long axis of the device and the outer sheath. So what are the strategies? We thought maybe we would try an ablation catheter, so to deflect in a way so it aligns with the axis of the outer sheath. And that was not really successful. Here is another view trying that using the deflection of the ablation catheter. But you can see there's a little bit behind. If we loosen this gooseneck snare, this can potentially embolize. So we're holding on to it. And we come from the top, from the IJ side, and have a second gooseneck snare. So you can see we're catching one of the tines from the IJ. We have two snares. One is on the body, and the other one is on the tines. So we use the second gooseneck snare from the neck to straighten out the device. So eventually, it gets taken inside the sheath, and it was taken outside the body. So this is a dual snare technique. I'm showing you from two different sides, from an IJ and femoral route. Eventually, this device was taken out. So some of the tools that you may need to be familiar with for a micro extraction, either a Amplatz gooseneck snare or a multi-loop snare, depending on your familiarity with these snares. And here's a report from the literature, an embolized micro device. The authors here describe a dual loop snare technique where they use a Agilis sheath, grab the body of the device with one snare, and use a second snare to align it so it can be taken out. So how does it look like? So you have a micro sheath, Agilis with one snare, and a second gooseneck snare for alignment. So there are a few reports out there. You could potentially use this technique to align the device to a larger sheath. Now, the specifically dedicated extraction sheath, both the Boston Scientific and the Abbott, they have these dedicated extraction sheaths. You can see that there's a tri-lobed tip that can be engaged by pushing this button forward and backward on this delivery catheter. So one of my colleagues who did a recent case using this particular, this patient was getting a BIV upgrade and they were trying to take the micro out. So here, it's hard to see on this picture, but you can see there are 3 loops here at the tip of this particular snare. The catheter itself has this deflection mechanism, so you can direct those loops towards the leadless pacemaker. So here, you can see that we engage the back button of the leadless pacemaker, the delivery button, with that tri-lobe snare. And once you have that, you have this protective sleeve that you can advance it over the device that can be used for counter traction. So here you can see that there is not much of a perfect alignment, but as you put a little bit more tension, eventually that protective sleeve comes over the leadless pacemaker device. You can see there. So that if there's a long indwell time, you should consider using this because this particular sheath gives you the ability to provide some counter traction on the myocardium. So eventually, this particular device was taken out. Gareth, I think you have a question there.
Just ask, is that so that's the Abbott sheath you're using to remove the micro, is it?
Yes, yeah. It's the Evere extraction, their extraction tool. So I think from my case, the take-home points, often when you have a leadless pacemaker infection, they seem to have a better prognosis compared to a transvenous lead. And many patients are treated with antibiotics over extended period of time and may not need to be removed. We learn as time goes by, we will have more and more data on this particular topic. So if you need to extract it, know the tools. You need to have like a deflectable sheaths, snares, and understand that dual snare technique for proper device and sheath and alignment. Dedicated outer the protective sleeve for counter traction if you're dealing with a device that's been in the body for a long time.
Great case. Yeah, actually, it's a couple of cases. So very nice, nicely done. I think we are facing the dilemma, and it's in the soon future because the first leadless pacemaker was approved in 2016. So nowadays, we probably have experience about the device maybe within 5-6 years. So most of the device we attracted for leadless device is because either device malfunction or temporary bridging using the device. So, but in another few years, we're facing, I think, a bigger dilemma is the battery life, maybe towards the end of the life.
Yep.
So I think at that time will come soon in a few years. So I think that we have to learn the techniques and gain some experience how to remove the leadless pacemaker. And then I want to see any questions from the audience. Can we open to the entire audience page so see anyone have questions? Here, I not see any. Any questions from the audience?
On that point that you've just raised, Dr. Cha, in terms of removal of non-infected micras in particular, I think it's a little bit different for the other companies. Is that something we should be doing or do you think we should be doing at the end of battery longevity, or do you think it's something we should be avoiding at all costs, or somewhere in between?
Yeah, that's a great clinical question here. So probably we have to depends on the patient situation, right? How young is the patient? How old is the patient? And what's the clinical scenario? And then, so if it's just it's non-infection, and then because the leadless pacemaker overall infection is low, as Siva already mentioned. So at the end of the life, patient is pacemaker dependent. Do we want to implant another device? Do we want to abandon or remove the leadless pacemaker? I think that probably that's deserve a future discussion because currently we really don't have much experience about the 10-year-old or 12-year-old on average leadless pacemaker battery life. So, and then it's not every leadless pacemaker is easy to be removed. We have seen some leadless pacemaker, when we remove it, and then whether we can cause the myocardial perforation, we don't know. We have incidentally found some leadless pacemaker with the tie completely outside of the epicardium. It's incidental just during the valve surgery. So the surgeon was curious, found that the lead tie completely penetrate the epicardium. So this is a scenario we have to think about. And then also some lead is completely embedded within the trabecular muscle of the right ventricle. And then we have seen some case report the surgeon, when surgeon take the leadless pacemaker out, when they doing other cardiac surgery, not the purpose for remove the leadless pacemaker, they found the pacemaker cannot be removed by the leadless extraction because they have to take time, use the knife to get the lead out, get the leadless pacemaker out. Even during the surgery, it's challenging. So I think there will be a lot of discussions when come to each individual patients. So I hope in the future with everybody's experience, then maybe we gain some literatures and then to give some clinical guidance for the future.
Practically, when I'm thinking, I'm a little bit cautious about taking it out just for the purpose of taking out in somebody who didn't have prior sternotomy. If they had a prior sternotomy, I'll be more comfortable taking it out at the end of life. And we had a few cases where you really need like ICE guidance to try to get that snare onto the back end. Sometimes they're so embedded in the trabeculation, it's hard to manipulate a larger snare, especially if you're in between the trabecula. You probably need a smaller snare and ICE guidance, some sort of ultrasound guidance to guide you to get that button.
Any comments, experiences from the audience? I think somebody raised the hand, right? Is it Sherma? Oh,
Yeah,
hand is off.
What do you guys do in Australia with these leadless devices? Are you taking them out?
So we've only we're pretty slow in Australia for a lot of device approvals. So they've only just had reimbursement approved in November. So some case there are a number that have gone in, but it's fairly low numbers. So I'm not aware of it. I'm aware of a couple that have come out talking to the lead extraction community. There may be a few others that have come out that we don't know about because it was the implanter who took it out. In cases of one was a definite early device endocarditis with a thicker vegetation I've seen around the leadless device. The other one I'm not sure. Both people said they found it a pretty unpleasant experience because you were just sort of pulling and hoping that the tines gave way before the heart. And it's interesting to see you use that counter traction sheath from Abbott that we don't have available at the moment here. They haven't got approval. So we're still very, very early in our experience of them, and our funding model as well in terms of bridging devices in we wouldn't cover that well. So you put a lot of externalized leads in, but I guess you guys get some experience just of of just doing the procedure of that. So too early for us to say really.
Yeah, so far we don't have a lot of patients with the batteries have completely drained and you have to add a second device. So I think we are getting to the point that we will start seeing them. And that will tell us, is it going to occupy a lot of the RV myocardium? And at that point, would be the inflection point. Are we going to be more proactive in taking them out?
Yes, definitely. And the animal study says, you can do 3. Yeah, but however, when we do the implant, it may not be that easy. And then make sure the device has no interaction.
Yep.
Yeah, so that in reality, how big or how small the RV is, if the location of the 2 devices really accommodate the goal. So we don't know yet.
Yeah.
Looks like I'm lucky because you guys will get to take out or have a go at lots of them, and then I can wait and see whether it's something that I have an appetite for when we get to that point.
But you're the cutting edge there. So
Right.
we learned a lot of tips and tricks from you today. Thanks for sharing your case.
Okay,
We're at the end of the hour.
Yes. So, and then if the audience have any comments, you can send the email to us. And then if you have interested in some other cases and have suggestions, also please let us know. Okay. So I want to thank all the speakers and the audience to join this webinar. And also I want to thank Ryan, Jeff, behind the scene organize this webinar delicately. Okay. So have a good evening and thank you again.